start with inspection. So I would ask the athlete to stand up for me. And then we'll look at the back from the side, but also look at the back from the straight on back. Can you take off your shirt for me? And we're going to look at the spine. We're going to do our range of motion too as well. So we're going to look at the normal lordosis of the cervical spine, kyphosis of the thoracic spine, lordosis of the lumbar spine. We look for any scoliosis. One way to look for scoliosis is you have the athlete bend forward. And we call this a forward bending exam. If you come over here, you can see a little rotation of the spine. So there's a little rotation, and that's the sign of scoliosis. So if you have scoliosis, not just lateral curvature, but you get a little rotation. And you can probably better see that rotation from the back here. So there's a little bit of rotation one side to the other. So now, stand back up. Put your hands on your hips. And in terms of full flexion, I thought that was full flexion. If an athlete can actually put their hands flat on the floor, that's exaggerated flexion, and we give that 2 points on the Brighton score. So put your hands on your hips and lean back and look at the ceiling. Lean back. So come over here and you can see the curve in the lumbar spine. This is actually decreased curve in the lumbar spine. So I would expect up to 45 degrees is normal, so there's a little loss of extension here. And so that happens with injury sometimes in the spine. So we expect a little bit more extension. And you can see that even when he was bending back as far as he could, the spine stayed a little straight. We can also do lateral bending, side to side. And again, the other side, you're looking more for symmetry here. It's got full lateral bending, and we can do rotation, put your hands on your hips and rotate your spine. Yeah, and if you get past 45 degrees, I consider that normal. Again, here, I consider that normal. So only thing decreases extension. Now we do palpation. Might as well start with the cervical spine, palpate down the thoracic spine, and importantly cover the lumbar spine. The iliac crest is about L4, L5, so we know where the L4-5 is, and below that is the sacrum. And so we'll palpate. If there's tenderness on the spinous process, we'll tell that. We can also sometimes feel tightness in the paraspinal muscles. Head over here and lay down. We're going to go ahead and check a few more things that will help us with back pathologies, and that may be some of our special tests. One of them is called the CV sign, and it's a straight leg test, and it normally described as any pain that radiates from the back to the buttocks or down the legs after you raise the leg probably 20-30 degrees. Pain in the first 10-20 degrees, it would be potentially a false positive. So we count probably 20 degrees all the way up to about 70 degrees. And after that, when you get towards 90, everybody's tight, and there'll be tightness in the hamstring, so that would be a false positive. So we would really count between 20 and 70 degrees. And if pain radiates to the butt or down the leg with this maneuver, that's consistent with something compressing the nerve roots leaving the spine. So that's considered a positive straight leg test. Now, if you have bad disc disease with that herniated disc putting pressure on the nerve roots, super bad on one side, any motion can sometimes tip the balance and cause pain down the ipsilateral side. If we want to find out if they have a big disc, we might do a contralateral straight leg. And just by doing this, there's a little bit of flexion in the spine. If that causes leg pain down this side, that suggests a big disc. So this is actually more specific test, a contralateral straight leg test than an ipsilateral straight leg test to define if someone has a sciatica. So if you lift the contralateral leg and the ipsilateral leg hurts, that's a less commonly found finding, but sign of a bigger disc. Now, if patients have posture element disease, sometimes they'll have other symptoms with this, and then this with this back exam. So what we'll do is have them roll over on their tummy, because above the sciatic nerve is the femoral nerve, and femoral nerve can be pinched anywhere between L2, L1, L2, L3, and even L4. And this nerve can cause leg pain too. We call it neurogenic claudication. And one way to detect this is we do the femoral nerve stretch test, where you flex the knee at 90 degrees and we elevate. And we extend the spine a little bit this way. And when we do this, if that reproduces pain down one side, that could be considered a positive test for spinal stenosis. Now, if a patient's having none of these symptoms, can you sit up for me? If the patient's having none of these symptoms, we can go ahead and do what's called a slump test. Now, the slump test is probably best noted with the patient sitting. And you can do a straight leg test here too. So if your patient is fibbing about their positive straight leg test, you can do it while they're sitting. If they say it doesn't hurt, if they don't make any face, then you know they are just masquerading they had pain. So that's part of the Waddell sign. So if they have no pain with this, but they have pain laying down, then they're just telling you masquerading, because this is also a straight leg test. Now, to accentuate the dural tension on the nerve roots in patients who have a negative straight leg test, who may have a small disc herniation that's pushing pressure on the nerve roots, we'll do the slump test. So the hands can be here, put your head between your knees, and then you raise the leg. Now this, if this reproduces symptoms, I'll have them extend the spine. If it feels better, that's a positive slump test. So positive slump test is a test that you do if the straight leg test is negative, because straight leg test doesn't hurt, but we add the extra dural tension from the slump that accentuates the pull on the nerve and irritates the nerve more over the small disc herniation. So it's called a slump test. Now, everybody who has an exam of anybody probably need a neurovascular exam. The critical neurovascular exam in this case would be patellar reflexes L2 to 4 and reflexes of the S1 dermatome at the Achilles. Strength testing. So I'll have the patient stand up and we'll do heel walk. And I'll usually demonstrate to them. And then I'll do toe walking. So they'll walk on their toes as well. Now, one way to detect power loss of strength is they may have full strength this way, but they may be a little bit decreased if you do one-legged toe raises, and I'll have them do 5 on each side and compare side to side. So if they have an S1 nerve root irritation, on one side they may be able to do really well, on the other side, when they do it, they may not be able to do quite as well, quite as high or quite as many. And that might be a sign of power loss, so it's a subtle finding of weakness.